Hello, everyone. So we're back at the first module where we're going to look at key design components of a randomized clinical trial. Now, there are 4 stages in testing new therapies. The first one is generally considered a phase 1 trial, which is unblinded, uncontrolled studies in a very few volunteers to test safety and to find the dose, to then conduct a phase 2 study, which are relatively small, randomized, controlled blinded trials to test tolerability and to measure surrogate outcomes to see if there is signal of efficacy. Therapeutic agents that make it through phase 2 generally move on to a phase 3 trial, which are relatively large, randomized, placebo-controlled blinded trials that test effectiveness of therapy on clinical outcomes. And finally is phase 4, the larger trials or observational studies after a drug is approved by the FDA to assess the rate or risk of serious side effects and other uses. The reason for just reminding you about these stages of therapies is to point out that in this series, we will be focusing on phase 3 trials. Because when you are considering translating what's out there in the literature to see if this might apply to your patient, you're more likely going to be reading articles that have conducted a study using a phase 3 randomized setting. Now, here's the basic schema of a randomized clinical trial. You normally start with a source population from where your sample will be derived. Now, we want to make sure, since we are going to be observing these individuals over time, at baseline, we want to make sure that none of these study participants have the outcome of interest. Once we've established that and set eligibility criteria that are met by the subjects, a group of subjects is then randomly assigned to the treatment group, and the other group gets the control intervention. As you can see, we prospectively follow up over time and evaluate how many people in the treatment arm develop the outcome and how many people in the control group develop the outcome. Now, here are the key features of phase 3 randomized clinical trials that you probably know, but you should definitely be aware of when you're reading a paper that claims to be a randomized trial. It must have a prospective design. There's usually an intervention or some treatment that is being tested. There is generally a placebo control. Randomization has been used to decide who gets the treatment. Blinding of the study subjects as well as the investigators who are measuring the outcomes, and follow-up of the participants. Now, all of these features add to the strength of the internal validity of the study. So let's look at each one and why they are important. A prospective design, which is inherent to a randomized clinical trial. Why is that important? Because a prospective design ensures temporality. This is a required criterion for causality because we want to make sure that the exposure of the intervention comes way before the outcome. Now, of course, while this is a big advantage of a randomized clinical trial, it poses a limitation. And this has to do with loss to follow-up, which could be a potential problem. And in addition to the fact that because we're prospectively following up subject, clinical trials take time. So the average trial is about 3 years, and I would say most of them are at least 5 years in duration. Now let's talk about the intervention or the therapy that's being used in the trial. So when you're reading a paper, you want to know the drug or whatever the intervention was. Did they pick something that was, of the right dose that would be effective? At the same time, was that dose safe? Is blinding feasible given this particular intervention of interest? Generally, drug trials are easier to blind. On the other hand, surgical interventions or non-therapeutic interventions such as relaxation or acupuncture are a little bit more difficult to blind. Is the trial looking at a single intervention versus placebo or a standard therapy? And these are generally, routinely seen. They are preferred to sort of a cocktail therapy where it's harder to know which out of these 3 drugs really was the effective one. And finally, you're looking to see how was this intervention administered. So generalizability to the way treatment will be used in practice is generally preferred because then it's easier to translate this in the clinical setting as well. Now, why is a placebo control one of the key methodologic features in a RCT? The reason being that a placebo group can control for non-specific effects, also known as expectation effects. Therefore, trials that only have one arm, which is the intervention, don't lend themselves to really evaluating effectiveness of that particular intervention, because just due to expectation, that particular arm might, subjects who got the intervention might just do better. So we generally use a placebo control when there's no approved treatment for an illness or condition. However, if a new therapy is being tested for an illness where standard treatment does exist, then generally the comparison group will be the standard of care treatment, and our new treatment is usually compared to one of those standard of care. Now let's look at the next feature, randomization. The sole objective of randomization is to achieve equal distribution of confounding variables between the two study groups that are being compared. And the reason we do this is so we can balance out both measured and unmeasured confounders that may spuriously result in a relationship between an intervention and the outcome. So just because a study says that they use randomization doesn't mean that you should necessarily believe that. We want to make sure that the procedures that were done truly allocated the treatments randomly. And how do we know that the randomization worked in a study? Well, check Table 1 of any published paper, which tells you whether these characteristics that they're reporting in Table 1, which are generally baseline clinical and demographic features, got balanced out between the two arms. The next feature is blinding. Why do we have to blind the study subjects to the interventions they're getting? The reason is we want to reduce the influence of bias in measuring outcomes that can be caused by the researchers and subjects' expectations about the treatment. So generally, in a single blinded study, subjects are blinded to which intervention they were assigned to. So are they getting the actual treatment or are they on the control arm? Blinding can really help improve adherence because if the subject has no idea whether they're getting the active drug or placebo, they're more likely to continue therapy. A double-blind trial is one in which neither the subjects nor the investigators know treatment status. This is one of my all-time favorite examples for why blinding is so important, especially when your outcome measures that are being evaluated are subject in nature. So this was a trial conducted by Mosley et al., which was published in New England Journal of Medicine in 2002, that evaluated whether arthroscopic surgery was effective in treating pain related to osteoarthritis. So previous unblinded trials and observational studies had shown that, arthroscopy of the knee does help relieve the symptoms. So they designed a 3-arm controlled trial where one group got arthroscopy, where they got joint debridement as well as lavage. The second group got only lavage of the joint without any debridement. And the final group got placebo, where they just did an incision and they gave them, some, breathing in air, and they were able to do sort of this sham surgery. Now, do you want to take a guess which arm did better? So here, if you look at knee-specific pain scale score during the trial, you can see that all 3 groups, the placebo, the lavage group, and the debridement group, were all about the same. So you see, even those who got the sham surgery, showed some improvement on pain. Now you could argue, well, let's look at some objective measure. And so they had another outcome measure that looked at walking and bending subscale. And you can see that even there, although you might think this is slightly more objective and less likely to be prone to issues related to blinding, you can see that all 3 arms did about the same. So this is just a wonderful example to show why blinding is so important and why we also need a placebo arm when we want to evaluate the effectiveness and efficacy of an intervention. Now let's spend a minute thinking about what are the outcomes in this particular paper. So the things you're looking for is you hope that this paper actually evaluated a clinical versus a surrogate outcome. And what do we mean by that? So for example, if you have a drug that lowers cholesterol levels, A surrogate outcome would be, lowering LDL levels, for example. But that's not enough because you want to actually make sure that this medication is also reducing the risk of having a cardiac event as well as reducing mortality. We want to make sure that whatever outcomes are being measured are being done so with precision and accuracy. So the diagnostic criteria is operationally defined and is being performed on all study subjects in exactly the same manner. We also want to make sure that the clinical trial is capturing a number of outcome variables, some that may be, very important from a clinical standpoint, but also things that are important to the patient, such as quality of life or their ability to go back to work and things like that. So, of course, this would depend on what the disease or the illness of interest is. And finally, all trials must report and carefully document adverse events. The final feature that we care about in a randomized clinical trial is the follow-up. We want to make sure that the inception cohort or the subjects that started the study were all completed to the end of the study. Why is follow-up of subjects important? Because it can minimize bias, as well as missing data problems, which can really threaten the internal validity of our studies, in addition to losing power. So in summary, these are the key features we're looking for in any randomized clinical trial: a prospective design, what is the intervention arm, what is the placebo control arm, is randomization done, is it possible to blind both the subjects and preferably the investigators as well, and was follow-up complete? I'll see you back in Module 2, where we will now talk about analytic approaches for deciding, whether the intervention actually is working. So see you soon.